Sure. Good morning again, everyone. I'm pleased to present our speakers. Our main speaker this morning is Dr. Lisa Ayoub-Rodriguez. She's an assistant professor at Texas Tech Health Center in El Paso. She's also a hospitalist at the El Paso Children's Hospital. She is passionate about the border community and its high rates of un- and underinsured, along with rates of poverty that have colored the region's medical landscape. She's been on the front lines of refugee surges over the past decade and has worked to organize local efforts to provide medical care to this vulnerable population. She's dedicated her career path to developing local experts in the field of border health by developing a border health curriculum for the pediatric residency program and working towards expansion to other programs. Our own residents here at the University of Minnesota have participated in this program for the first time last year. She considers her life work being an advocate for underserved and immigrant children and has spoken nationally as an expert on immigrant child health. With us today is also her colleague, Dr. Itai Moreno. He's also assistant professor at Texas Tech Health Science Center in El Paso and a hospitalist. He's the medical director, in fact, of the hospitalist program at El Paso Children's Hospital. It is his personal and professional goals that brought him back to his home to serve his local community. And throughout the years of practice, his community has expanded to encompass a diverse population of patients, ranging from the underserved to the unaccompanied. In El Paso, he has participated on the front lines battling key issues affecting the border. His platform and positions have given him the tools required to make providing proper medical care to the refugee population a local priority. Education, advocacy, and community service are the primary pillars that define his mission. And through the border health curriculum and mentorship, he instills his mission to future generations of physicians. Welcome to both of you.
Thank you so much. It's great to be here, and I really appreciate the opportunity and the interest that you guys have in hearing about this very interesting and unique story we have here on the border. I am thrilled to have my colleague, Dr. Itai Moreno, here with us today. I developed laryngitis the last couple of days, so he has come to rescue me today and share his wealth of knowledge and experience. So a special thanks to him. Today we'll be talking about caring for children on the US-Mexico border. And yes, we had the opportunity to share in your residents who were phenomenal last year. They really provided such great context and insight from the perspective of not being on the border and what you guys see. So we really enjoyed that opportunity. We don't have any disclosures this morning. We'll be talking about the border population and the unique considerations that we see in healthcare delivery. Hopefully that will paint pictures for you and the journey that the immigrant population that you may be taking care of in Minnesota has been through and where they were before they got to you. We'll categorize the social determinants of health when caring for children on the US-Mexico border and propose some strategies when taking care of the immigrant population. Let's start a little bit with orientation. So the US-Mexico border extends from the Pacific Ocean in the west to the Gulf of Mexico on the east. It traverses a variety of terrains. There's very urban areas, the San Diego, Tijuana border, the El Paso, Juarez border are very urban, and it spans through deserts and rural communities as well. It's the most frequently crossed border in the world. You'll see lots of pictures of that. Approximately 350 million legal crossings are taking place annually, and it extends 3,145 kilometers from that Pacific Ocean to the Gulf of Mexico. There are 48 border crossings along the border, and there are 14 cities in the US and 14 sister cities in Mexico that line our border. So the border region of Texas, of course, everything is huge in Texas. We were just talking about before we went live. Texas has 2 time zones, and El Paso gets to be the one in mountain. The rest of Texas is in central. So not only do we have 2 time zones, but we have a huge border region that is actually the same square miles as Florida, Wisconsin, Georgia. And what is considered the border is 100 kilometers north of the border and 100 kilometers south. So that stretches 1,254 miles. And it includes also some tribal nations. So we get a lot of Native American populations as well. In just Texas alone, we have 8 of those 14 sister cities, with El Paso Juarez being the largest. The Texas border currently has 3 million residents. And if you think about the El Paso Juarez multiplex, it's actually 3 million residents in that whole community. So I like to think of us as the largest border community in the nation. San Diego and Tijuana definitely have more population than us, although we are literally, I can see Mexico from the window that I'm sitting at. So I can walk from here to the border and the bridge and get there within 15 minutes walking and a couple minutes driving. So we literally are kissing cities, whereas there's a little bit more distance between the Tijuana and San Diego border. So this is an aerial shot of our city, of the borderplex, or we call it the Paso del Norte, which is the pass to the north, which I think is a great term for our community because it really is the welcoming door of our nation. So here you see our beautiful downtown, and you'll see this highway in the northeast portion of the screen, which is the border. And where you see that X and that greenery, that's actually Juarez. And all of that in the background is Mexico. And one cool thing about the El Paso Juarez area is it is a major center for manufacturing and international trade. It's one of the largest ports of entry in the US-Mexico border. It's the region is the second most important point on the border, the second most important trade point on the border, and the 14th largest trading center in the US. $81 billion in trade will take place in this region. And as of, I don't have a newer figure, but as of 2010, there's more than 70 Fortune 500 companies. I think this is so interesting to point out because you will hear us talk a lot about the disparities in this area, yet there is so much economic wealth and opportunity here. So it's interesting that with all of that, we still have quite a lot of disparities to share with you today. This is a very typical morning picture. You see on the right hand of the screen is the line to get into the United States. And you don't see a line coming into Mexico usually at the beginning of the morning. This is a common commute that a lot of our local population take every day to get to work, to get to school, to live their lives, to go shopping. And it's a scene we're quite familiar with. This is the opposite direction in the evening time as the sun's going down. You see again the cars coming back in. So a lot of our population, they live binationally. So there is a fence, there's a wall, but their homes are both homes. And that has really interesting, unique healthcare implications. This is a picture that we here in El Paso are very familiar with seeing. I remember this as a kid. We would go to Juarez for a haircut on Saturday to go get some lunch, to go eat in the mercado and listen to mariachis and really have a wonderful day. And we would see all of these vendors where you can get the best paletas, which are Mexican popsicles, and you can get all kind of artistry work, blankets and guitars, and anything you can imagine is sold on the bridge. There's a lot of fond memories. And Dr. Moreno wanted to share too.
Sure. So this specific picture, you know, it brings me back to my journey. So I lived in Juarez and I would commute to El Paso. every day. So this was my life for approximately 14 years. And one thing that stood out, I was like, it's usually the wait time is between 1 to 2 hours. But I would every so often I would see ambulances cut through the line. And as a selfish 10-year-old worrying about getting late to school, I would always wonder why or how they were able to cut the line. Now, as a practicing physician on the border, I understand that these children were usually U.S. citizens or non-U.S. citizens that required immediate medical attention. And what's frustrating now, before the frustration was the wait time, now my current frustration is that sometimes those ambulances are turned away. So I think that's one of the huge issues that we face during here in the border.
So going back to emphasize the border crossings. So there are 30,000 cars that enter the US daily, over 20 million vehicle passengers. Pedestrian traffic is huge, 10 million per year. And it's super easy. Now that's kind of the preferred method to cross because of the wait times. You park on this side of the border, right a few blocks away, and you just walk over, and you can take an Uber to go get some lunch or to go to the pharmacy, which we will talk about how that happens often here in this community. So this interlacing of our community is super critical. Again, just kind of highlighting those northbound crossing and the southbound crossing and pedestrian crossing happens every day, all the time, for every reason. This, I think, is a really important picture to highlight. This is our patients. These are our patients who live in Mexico. They go to school in El Paso, and they come and see doctors here. And we see them in our clinic. We see them in our hospital. And they really present a unique perspective, but also some unique challenges. So something that the community or the world might see often in news media outlets is our border fence. You'll see it here, and you can see a little bit of, besides the height of the border fence, which is between 18 and 27 feet, you have this, the sand has been cleared. So you see some lines, and that is another form of helping with border security. So if anybody was to jump the fence and make it without being injured and being able to run, then they can track the footprints. They also have seismic technology, so they can they can sense the vibrations, and also video technology as well, and motion sensors. And then also Border Patrol are often stationed frequently in the more traveled areas. What we've been seeing, the populations that we see of patients really fluctuate as the political climate changes. Recently, we were seeing a lot more traumas from crossing over the fence. So we had spinal injuries, all kinds of limb injuries, amputations. So really, really tremendous trauma from the fence. You'll see the fence goes from the most traveled areas, the urban areas, to also very rural mountainous areas as well. This is our, if this plays, yeah. This is our daily drive to work. So we are driving on our way to work, and we are looking into Mexico, and often seeing on the way home from work, there's a soccer field, and seeing kids playing soccer right in our neck of the woods in Mexico. But really what the border looks like to us is a big playground where kids are connected. This is an art installation that was put up a few years ago, and it just illustrates how connected we are and how we as the sister cities help to pick each other up and how integral we are to each other. The US-Mexico border has a growing population. Over the last decade, we've gone from 18.3 million to 19.1. And just talking about the border in general, it's quite diverse. We have 50% as expected Hispanic population, and a smattering of other different racial ethnicities. I thought this was interesting, and we want to highlight all of these factors because they all play into our social determinants of health. So educational attainment varies widely by border state. So you'll see that if you look in the green, the border average for having a high school or less education is 40%. But you'll notice that there is a wide distribution. So in California, that drops to 37%. In our great state of Texas, we unfortunately have the highest less educated population at 53%. So I thought it's interesting that we have a similar demographic, but for some reason the opportunities are not the same. And we all know what that means for our patient population. Without that education, that predisposes you to lower paying jobs, more unstable income, and therefore leading to a slew of other consequences in healthcare. It's, I think, a common misconception that most people in the southern border may not be US born. Actually, if you take a look at this spreadsheet, compare the US average, compared to the US average, border residents are twice as likely to be immigrants. In 2018, 23% of border residents were born in another country compared to 13% of the US. So half of all immigrants in the border region are US citizens. And the highest share of immigrants in the border region are in California, where a quarter of those are born in another country. 21% of border residents are immigrants, followed by 13% in New Mexico and 12% in Arizona. Unemployment rates of the southern border. So you see our US average as of 2018 was 4.9. The border region is always a little bit higher at 5.5. And then you can see the differences between the different border states, with Texas being one of the highest. Arizona also and New Mexico kind of share similar. So thinking about that and the unemployment rates.
Yeah, I mean, I personally think that this is the key issue that affects our community. You know, when employment is a problem, we immediately lower healthcare as a priority. You know, we focus on other more pending issues, you know, such as shelter, food, and so on and so forth. So unfortunately, you know, those well-child visits or just access to medical care just doesn't really make the top of the list.
And you see that highlighted as well in the poverty levels. So yellow is the US, and then you can see the border region and the poverty rates. So the US has a 12.8% poverty region. Poverty level. Border is 14.6, and then you see the different states with the highest poverty being in Texas, 23.7%, which is about twice the poverty rate than the US average. So I think you all are very familiar with how that is going to affect all of our children here on the border. The US national rate of uninsured has seen an uptick of uninsured over the last 5 years, up to about 5.7. When we look at, this is from 2018, it's the most recent I could get, you can see that same line that I showed you zoomed out in the very dark brown. So you see a small uptick, then you see the disparity of, after a decade of decline in uninsured rates among children, there's an increase for Hispanic children from immigrant families having an increased uninsured rate. So it actually is close to about 13%. So a little bit, 2.5 times more than the national average. When we look at Texas, oh, this is like the walk of shame. I love being in El Paso and I love being a Texan, but when I look at this, I am so sad that we are 51st in rank on children having health care. You guys are, is it 7 or 8? 8, and you are above the national average. So we definitely need to learn from you guys. But you can just imagine when we're taking care of patients, especially in the hospital, trying to coordinate care with this population that doesn't have the ability to get the follow-up care as readily, get the DME that they need, get access to all of that coordination of care. This may be one of the reasons that we are not as high on the list. So I compared Texas to Minnesota. Sorry, it's a little cutting off. So your eligibility level compared to ours for Medicaid ages 0 to 1 is almost 100% higher, and it's over 100% higher for our ages 1 to 18. And then you guys also have your pregnant women eligibility level is higher, and then also so Texas opted out of the Medicaid expansion. So you'll notice that in the far right where we have eligibility for adults, parents, if you are a parent or a caretaker, if you are 14% of the poverty level, you could get some Medicare. That's a very small population. Medicaid, sorry. That's a very small population. But if you do not have kids, you have 0 eligibility for Medicaid. So you guys have really done an amazing job with that, in that if you're 200% above poverty level, then you can get at least something. So it's very common in our population for a lot of adults to be walking around without health insurance, and even parents. And we know the consequences of that. We'll talk about that, I think, in another slide as well. So this is just our numbers for El Paso County. We're a little better than the rest of Texas, still close to 10% uninsured, and uninsured adults. This is reflected from what we just talked about, our Medicaid eligibility and what options there are for adults.
And again, I think being uninsured is as hereditary as your common diabetes. As again, going back to unemployment, is that if your parents are usually uninsured, more than likely the child will be uninsured. And again, putting healthcare as a lower priority.
And I love how you were talking about before, is it becomes a cultural thing, right? Like when you don't go for well visits, you're not going to take your kids for well visits. There actually was a study in 2018 that showed that children whose parents are more likely to have a well visit, the child was more likely to have a well visit. So healthy parents are better equipped to care for their children. We know that. Insured parents mean less out of pocket spent on healthcare, leaving more money for other things, including food and housing. It's not uncommon when I'm rounding with the residents to tell them, do you realize what this hospitalization is going to do for their entire family trajectory with an uninsured family? It is literally going to completely put their financial situation in demise. And how are they going to ever come out of this $10,000 hospital stay when they're going check to month to month on that? So this is a huge factor when dealing with families, is how much it can really change the trajectory of their future. So we know, I like to kind of think about immigration and how it transcends all social determinants of health. We've already talked about how it affects access to healthcare. We've talked about a little bit of how education. So immigration will affect your ability to get potentially get an education. We have talked about economic instability, social and community context. A lot of times you want to fly below the radar. It's not uncommon for us to see families who are hesitant to get involved in the parent-teacher associations at school, get involved in neighborhood collaboratives, advocacy collaboratives, and those kind of things out of fear. So jumping into our unique healthcare population in the border city, we broke it down into 4 different categories that we kind of see a lot of. We see the binational families, which we've kind of hope to highlight that context that we've shared with you already. We see international families, so families that live in Mexico that come into the US for that opportunity for hope, for better healthcare, to get something taken care of. And a big feature of our last several years has been the migrant and refugee population, which we'll dive into. Something we will touch on in a minute as well is medical tourism. So there's people from all over the nation, you may know this, that come to Mexico or to come to a border city, to Tijuana, and get stuff done, plastic surgery, LASIKs, all kinds of elective procedures, dental. Our nation struggles with adequate dental insurance, so people will come to Juarez and take a bus over for the day, get their dental work done, and then come back. So that's something we see a lot. Going into binational families, so we've divided them into different categories to think about. So there's a lot of people who are US born, but they live in Mexico. They spend their weekends in Mexico, and they come for work during the day. So if you do not have a US address, you do not qualify for Texas Medicaid. So even if you're US born, if you do not live and reside in the United States, then you will not qualify, which is a common. We can go during rounds right now and definitely have that circumstance. I have a patient that we're taking care of who has spina bifida and recurrent urinary tract infections. And she used to live in the United States and has moved because of mom's immigration situation to Mexico. So she has a lot of challenges crossing with COVID. She couldn't get to her doctor's appointments. She has tons of DME needs, her straight caps, she gets rectal irrigations. And so it's been a challenge kind of navigating that binational living. Sometimes they live in the United States. If their economic situation changes, they may go to Mexico, or they may prefer living in Mexico. So kind of imagining what that means for us, taking care of them every day. We have foreign-born patients, those who they live, usually they were born in Mexico, but they live in the United States, usually undocumented, and they do not qualify for Texas Medicaid. So they kind of are living under the radar, but when something goes bad, they come to the hospital. Usually they're the population who does not really get preventative care. So you see disease states in a more progressed fashion. And then you have the binational living. You have the families who, like I've said before, live on both sides of the border, or they have mixed immigration status within their family. So there may be some generations who are not documented, some generations that are. They may qualify for Texas Medicaid based on their circumstance, but there is a big fear associated with accessing public benefits and what those implications are.
I think this is important. It's a great slide. This was a very common misconception regarding being US born and then qualifying for Medicaid. I was under that mistake, living here on the border, and it wasn't until I actually started practicing that I understood that, just having the luxury of being an American citizen doesn't necessarily give you access to our healthcare system. So a good kind of bridge to access to care. So access to care, I'm sure is an issue nationwide. Something that adds to that issue here on the border is the quality of access to care. Like Lisa mentioned, our patient population encompasses both both sides of the border to include Mexico. And you know, my medical journey has given me the luxury to be able to practice at every point of basically at every institution that I'm going to talk about. And I want to start by saying, you know, the intentions are good, the quality could be better, but I think the biggest discrepancy is resources. So, you know, the Red Cross is probably the first place that our patient population would go to if there's an issue with a financial issue or even a time issue. So this would be the expense would be minimal. It's basically donations. The time of waiting is of approximately, depending on how busy it is, it could be to 4 to 6 hours. And the qualifications of those practicing there are basically intern level, just fresh out of medical school. So I'm sure their intentions are good as mine were, but the resources and experiences is not ideal. Another option for our patients to acquire medical care would be your local pharmacies that are kind of have a hybrid model with a medical office. Again, the access or the wait time is minimal. Unfortunately, these pharmacies are approximately almost every other block in Juarez. The qualifications, again, it's freshly graduated medical students, and the financial cost would be the equivalent of maybe $3 to $5. Going on to the
Real quick, Dr. Moreno, so if you're practicing there, is it a benefit to prescribe?
Yes. So again, like I have had the luxury, and I say luxury to work in all these institutions, and there is a definite incentive to prescribe medication. Is basically the more medications you prescribe, the higher your salary. So there is a kickback kind of system, which you know could lead is a slippery slope.
And I remember, I think that's where I got my medical care as a kid. I would go and I would get shots of penicillin in the rear.
Yeah.
And so that was a standard. And my family still thinks that that's what you need.
Yes.
So with my laryngitis, and I told them I had to give a grand rounds presentation, they're like, go get a shot.
Yes, absolutely. Going on to so this is an equivalent of a county medical hospital. This actually is, the qualifications are top tier. You know, you are mostly board certified physicians. The issue there, and the cost is minimal. It's basically free, but the wait time, because it's being free and the high qualifications, could be up to months. So this is again very minimal opportunity to have, you know, preventive care, well-child visits. This is where you basically go if you have something actively acute wrong. This would be the private aspect of the medical healthcare system. Again, qualifications are usually board certified physicians, but the cost is significantly greater than all the other options. We're looking at probably between $50 to $75 per visit. And again, that wait time could vary, but unfortunately, the majority of our patient population don't have the financial means to acquire healthcare in this institution. And then your local friendly pediatrician. Again, the cost can vary. The qualifications are board certified, and the wait time is mostly accessible. But when you have all these other options that are less expensive and basically zero wait time, the likelihood that they will be seen by a board certified pediatrician is minimal.
So we can tell you hundreds of stories of our binational families. This is one that sticks out to me. Belém was a 12-year-old. She had fever for 2 months. She grew up in a family like mine. She's a U.S. citizen, but her family wanted the quick fix because they're also accessing care here in El Paso, you know, sometimes the weights are not good, or sometimes you don't get exactly what you want right away. So she went to Juarez and she would get shots in the butt. So she got a few shots in the butt. That wasn't working. She continued to have a fever. So she got a few prescriptions for antibiotics. I remember she was on amoxicillin, she was on Augmentin, she was on lots of different stuff kind of intermittently. But she continued to have those fevers. So she was given the fevers continued to linger. She slowly began to have decreased energy, decreased PO, and some confusion, which is when I met her. So she was found to have a loculated brain abscess from a complicated sinusitis, which required drainage. That was after just too much partially untreated infections. So we see those children without primary caregivers. We see children who have gone back and forth in the healthcare system, just kind of doctor shopping. I remember a patient with HSP, just super simple, but ended up having a flare, was on some actual immunologics, like some chemotherapy agents for a simple HSP. So you can imagine, like, yeah, if they have readily access to a pharmacy, and you can get all kinds of things that might not have that full investigation that's necessary. We have an interesting story that I think impressed both of us. Is we had a US citizen, he was about 12, he had osteosarcoma, he was cured from that, but he came in with osteomyelitis of his hardware. Mom lived in Mexico. He lived with dad in the United States, who was a truck driver. So he would spend most of his time in Mexico. And because of that, he couldn't get his PICC line and his antibiotics, and he needed like staged debridings and things like that. And he was going to lose his hardware because of logistics of living situation and doing like home health and those kind of things. The international patient, we'd like to introduce you to Lorenzo. He was just here last week. So this is a Mexican citizen who came in with bloody emesis because he was in a Mexico hospital and they were concerned, so they transferred him here. He was found to have esophageal varices due to unknown before that he had some portal hypertension from a portal vein thrombosis that had occurred. So he came here to us, and we got him taken care of. He really needs like a TIPS procedure, but because he is a Mexico citizen, it would totally be charity work, and our hospital here does not do that procedure in this age range. So it would be sending him somewhere to like Texas Children's or something like that. So we had to figure out how to coordinate care, and we were able to get him in contact with a Mexico City facility that can take care of him. But it's interesting to have to coordinate care with those kind of things. Do you want to talk about Gabby?
Definitely. So Gabby is one patient that, you know, I'm sure we all have that one patient that we remember fondly. The reason I remember her so well is she was basically my patient through the majority of my residency. Unfortunately, because of her circumstances, she lived here in the hospital for over a year. She was TPN dependent, and because she was not a U.S. citizen, she did not qualify for Medicaid. She wasn't able to get home health, which she needed to get home TPN. So we tried relentlessly throughout her hospitalization to try and coordinate something in Juarez that would accommodate for her nutritional needs, and unfortunately, that was not the case. So it wasn't until the hospital, the foundation, we figured out a way just to get her daily TPN donated, so she was finally able to be discharged from the hospital. But that was something that, you know, taught me the sad reality that, you know, there's some patients that their best hope or their best chance of surviving is actually to staying in the hospital.
A super important part of our patient population is the migrant and refugee patients. So it is not uncommon to see a Border Patrol agent in our pediatric ward sitting outside of the room or at the end of the hall. And they will be they will have the custody of the patient, which could either be an unaccompanied child or a family unit. We've mostly been seeing Haitian family units over the last couple of weeks. I put a star by the funded population. So when they're in Border Patrol custody, they are funded. What has been happening lately is that the family units are released from Border Patrol custody while in the hospital. So 2 days ago, I was taking care of a patient with an asthma exacerbation, and they needed a nebulizer, they needed albuterol. And once I gave the prescriptions for those things to the Border Patrol agent, by the next day, they were no longer outside of the door. They didn't talk to anybody. They released the family, and now our foundation is responsible for getting the equipment they need, getting them a car seat, getting them a ride to where they're going. So the case manager, I ended up finding out that the case manager paid our company to, our ResMed company for the nebulizer out of pocket. And it's things like this that we see all the time. I had a family 2 months ago. Daughter came in with a history of being on oxygen, but in their journey over the last month, they lost the oxygen tank fell out, had a G-tube, but they also didn't have a way to feed her. The tubing got awry, and they've just been feeding her by mouth for the last 2 months. And then the patient was with dad, which sometimes dads are great historians, but he had no clue. So the mom was in Border Patrol custody, and it was just a really interesting circumstance. Also ended up getting released in the hospital from Border Patrol custody. And again, not being funded at that point. We have our unaccompanied children in ORR custody, which can be a couple of levels of ORR custody, which we'll dive into. And those kids are funded. And then we have our Afghan refugee patients, which are funded. And then the Haitian patients, depending on where they are in the process, may or may not be funded. So again, this kind of highlights the possible points of contact. We can contact our patients in the migrant journey, so falling off the wall immediately when they're in CBP custody, which is supposed to be like 72 hours, pretty brief. They can be in El Paso hospitality shelters. So they've gotten released from Border Patrol custody, and they get to these hospitality shelters, which are nonprofit shelters, or where you guys see them in their sponsor destination as they're waiting their court hearing. And then the Office of Refugee and Resettlement, emergency intake shelters we'll deep dive into, and then licensed shelters as well. So again, on the migrant journey, we can see them usually trauma related. And then a picture of where they are in the Border Patrol custody. You've seen this before, the Yelera, or the ice box is what it's called. And then this is actually our hospital. The picture was from a CNN reporter who kind of snuck in and got a picture. And there's a Border Patrol agent in our hallways. The hospitality centers here in El Paso, called Annunciation House, is the biggest nonprofit that takes care of the immigrant population, and they'll stay in here until they get assigned to their sponsor location. So I think you guys all know who unaccompanied children are. It technically stands for unaccompanied alien child, but I like to emphasize the A in accompanied to be the UACs, but that's the official definition. It's basically anybody under the age of 18 arriving to the US border without a parent or guardian and without legal status. The important thing to know is that they are entitled to rights, which we'll talk about. So when you think about a UAC's processing time, they should spend a very short amount of time in CBP custody, which is why we can see them here in El Paso, but you guys probably won't get to see them in CBP custody because there should be out of that in a short amount of time. As the waves of influx of UACs come in, it will it'll oversurge the population that CBP can handle. And that's where they had developed ESIs, or emergency intake shelters, which we'll talk about. And then they should, after that, go to an ORR facility, which could be an emergency intake shelter or could be a licensed facility. So we see them from both of those, and they have distinctly different healthcare situations. And then the average time for waiting for an immigration hearing is 2.2 years. So I think you guys also know why UACs come. We all hear about the high violent rates of crime and gang violence. Something that I think people don't talk about too much is the pull factors, such as economic opportunities or the desire to reunite with family members that are already here. And the desperate determination that families are making to say that it's safer for their children to attempt to come alone to the border than to remain at that risk. I hear from my family all the time, did you hear on the news that kid got dropped off at the border? And it's, I mean, what was the circumstances that led that family to make that drastic decision? So detained migrant children have rights. It all came from 2 decades ago from the Flores Agreement, when the housekeeper of an actor in Mary Tyler Moore, her daughter was being held in a hotel in immigration custody, and that led to the Flores lawsuit, which ended up listing a lot of rights for detained migrants, the right to be held in the least restrictive setting, which is why you'll see them trying to get kids out of Border Patrol custody quick, the right to be released from government custody without delay to parents, family members. So it should be quick. And we were seeing definitely the emergency intake shelters were taking 2 months, that kids would come to the hospital and we'd be like, how long have you been there? Oh, 60 days or longer. Rights to provision, food, drinking water, medical assistance, immunizations, adequate temperature control and ventilation. I heard countless stories from moms with newborns in Border Patrol custody, and they're like, it's freezing. Like my newborn is, totally acrocyanotic and blue because they're so cold. It's just so hard to maintain that temperature. Because of time, I'm going to skip through some of these demographics that I think you guys have heard about. I do want to point out that in 2021, our numbers have skyrocketed. So we're close to 150,000 unaccompanied minors in 2021. Something important to mention is the emergency intake site. So that was developed recently in the last 6 months, and the purpose is to get children out of Border Patrol custody and into HHS custody as quickly as possible. So it's meant to primarily service teens, and so these are not licensed, so the challenges have varied across sites. We'll jump to Fort Bliss, which you may have seen on the news. It was a tent city that got established overnight. So over 5,000 UACs were there at one point. This is in the peak of, not the peak, but in definitely time of COVID. And we saw horrendous stories. So one I can remember, there was a kid with a kidney stone who we told, like, he was here with us for like 3 to 5 days, and he was doing fine. So we discharged him. We're like, just stay hydrated. Make sure you're drinking. He comes back 2 days later because he couldn't drink because he had to pee in a water bottle because they had huge lines to the porta potty. Another kid came in with 4 GI bugs. He had salmonella, he had shigella, he had norovirus, he had sapovirus. We discharged him when he wasn't having very much diarrhea. I mean, it was like twice a day. He had come in with like 17 times a day. So we're like, okay, like that's pretty stable. But he came back, he was pooping himself because the lines to the porta potty and the designated times where you could use the restroom. I mean, just very simple appendicitis. We just needed them to get some Tylenol. They couldn't get any pain medicine, so they came right back 2 days later. The conditions, tons of iatrogenic conditions. They were spreading strep all over. We had strep of every kind. We had glomerular nephritis. We had retropharyngeal abscesses with mediastinitis. We had empyemas. We had like 5 strep empyemas in the hospital at one time, all from the camp. So it was interesting. It was really a cool experience. We had daily meetings with the licensed medical contractors there who were in a horrible situation, having to take care of such high volume with very minimal resources. And the CDC was here. So they were amazing to learn from, and they contributed to like isotyping that strep, trying to isotype it to see what the strep strain was, and also just kind of helping with infection control. So that has been truly a unique and I would say historical opportunity.
One thing that I did take from this, it was very encouraging how we adapted and changed our practice patterns based on the situation. And fortunately, it did get better, but it required a lot of coordination, a lot of communication on both sides.
And a lot of advocacy, heads up to props to the AAP. They came down here twice. They toured the Fort Bliss camp. They talked to people. We met with them and explained what we were seeing. So they really were impactful in getting things changed. The more controlled setting is the licensed shelters, but also it's variable based on who licensed them. So some of them are really well equipped. They do have to have specific services, but you can tell when a kid comes from a licensed shelter or rather than from Fort Bliss, it's like, oh, train wreck versus like actually they can get medications. They can actually get re-screened. So the unique healthcare challenges I think are obvious. When the kids come to us, they're in the hospital. Can you imagine being diagnosed new type 1 diabetic without any family support, learning how to do carb corrections and those kind of things? It's almost impossible. They have to become self-advocates when they're in the camp setting, when they're in the hospital. They have to speak up for themselves. And we try to promote that and help that. They have the trauma and the stressor of uncertainty. It is, we have walked into countless rooms where teens are crying because they're in the hospital, they don't have anyone to talk to. It's really a trying time, and navigating the complex healthcare system and lack of access to their basic needs. We can go on, but I know that the time is short. We have had Afghan special immigrants with lots of interesting issues and lots of other populations, but I think it's important to give an opportunity for questions because I think there's only 5 more minutes. I really appreciate the time that you guys have taken throughout your day today and hearing our stories.
Well, excuse me. Please go ahead for our audience to put things in the chat or the question and answer. And I just want to thank you for what an incredible presentation, and mostly to just laud the incredible work that you're doing. I think you're, I can't imagine the extra mile that you go every single day for your patients. So thank you for all of your work. I will, just my ignorance, I did not realize that different states could set their own Medicaid eligibility levels. So you taught me that today, and if you have more to share about that, the way that our structures and policies inform health outcomes is so fascinating. So if you have a resource where if we want to learn more about that, or how can we advocate for better coverage for kids?
Yeah, I think that is a key opportunity. I think the advocacy needs to happen in Texas for sure. But to find out more, the website that I got that from, it's called City Trends, not Child Trends. I can pull. Oh, it's not on there. I apologize. Yeah, so it is. I'll put the link in the chat, but it's readily available, and you can compare all of these states to each other and see the discrepancies in that. So it's really interesting.
We have a question from one of our BMT faculty, Dr. Ebens. Thanks for sharing your experience and work. What most gives you hope and motivates you in your day-to-day?
Oh, Kristen is my co-resident. It's so nice to.
Oh, fun.
It's nice to connect virtually. Thank you, Kristen, for joining us today. You know, the patients, like that is why I love being here, because you get to help that patient in most desperate need. So it really is like daily rejuvenating. I mean, you can't always help them, but when you look in their eyes and they're like, thank you so much, doctora, like you know that what you did today made a difference. And I think, we talk so much about burnout, and when you love what you do and the patients that you're taking care of are so appreciative, it really is heart nourishing.
Absolutely. I think I can speak for both of us. So that's the reason we came back home, like to serve our community. And now we have the luxury to serve, our unaccompanied minors and our Afghan special refugees. And they're both, it's so gratifying to see the appreciation and just how minor effort from our standpoint, whether it's just, taking the extra time to counsel them and listen to them, really makes
That's wonderful. One of the was just thinking about the unaccompanied minors and how we think about transitioning kids who have lots of access to care to be able to take care of their care as an adult, and some of the transition checklists that they have for adolescents. Are you thinking about any kind of like curriculum or way to try to help these young people who have so many new things to navigate, like demystify our system and how it works?
Yeah, a lot of our population is so acute, and I think that there's so many leaders in that realm nationally who have taken that on. I know Texas Children's has an amazing, they got a grant for working on transitioning and building a community network to a home, a community home for them, helping with schooling transitions and then access to healthcare as well. So I think that nationwide, there are large growing immigrant populations. The AAP has a great council for child and immigrant health that also focuses on that as well. So locally, we're more like the acute triage, and then they go to you guys. So yeah, I think there's lots of resources out there nationally. SCAN network, specialized care access network, is a great resource to get kids hooked up with specialists throughout the country.
Thank you. Just a message from one of our nephrologists, Dr. Nahira, who writes, I grew up and trained in Texas. It makes me sad that things seem to have worsened with regards to medical care and have not changed with regards to education. Thanks for all of your work.
Oh, thank you. And we would love another neurologist. So
nephrologist, but yes, probably need those too for all the post-op glomerulonephritis.
Urologist. Yeah, definitely too. So come back to Texas, or but I shouldn't recruit with your probably department chair here.
I think he left, so your secret is safe. I won't tell him. Well, thank you so much. This is just your work is really inspiring, and I think certainly we can draw some lessons for the immigrant and refugee families that we have the privilege to care for here in Minnesota as well. And yeah, look forward to continued partnership. I know our residents on the global health track have really loved their opportunities to learn from you. So thank you so much for being here today. Thanks to our audience. Make sure to log